All right. Well, thank you all for joining us today. We have a very timely webinar ready for you, exploring the rapidly evolving landscape of digital health reimbursement. As virtual care and RPM models continue to fluctuate after the PHE, and AI-enabled tools are becoming more deeply integrated into care delivery, I think we all understand that the policies and payment models that support them or don't currently support them, the ones we don't have, are becoming increasingly important to discuss. So we have gathered today a panel of policy and digital health leaders to help us break down the latest reimbursement trends and answer some of the burning questions around the current and future state of payment policy. So before we get started, we'll do some introductions and then we'll just jump right in. I am Brooke McSwain. I have the honor to be moderating this group. Today, I am the Senior National Policy Analyst for the American Heart Association, specializing in digital health. And I'm going to turn it really quick to Jeff, who is immediately to my left. Jeff?
Thanks, Brooke. Hi, my name is Jeff Abraham. I'm a partner at Health Advances, a healthcare strategy consulting firm where I help run the medtech and digital health practice, and my background is in market access and reimbursement.
Awesome. Ryan?
Hi, everyone. My name is Ryan Keith. I lead business development at Cadence. Prior to Cadence, I was with HCA Healthcare. At Cadence, we partner with the nation's most progressive health systems to deliver monitoring and virtual care solutions. It's a pleasure to be here today.
And Sharif?
Hey everyone, I'm Sharif Vakili. I am the co-founder and CEO of UpDoc, also a primary care physician on faculty at Stanford. And at UpDoc, we're developing regulated clinical AI systems.
Great. Thank you, guys. I think maybe it'd be best if we just started, from a very quick review of what the current reimbursement landscape is. So, and chime in if you think I miss anything here. But right now, I would say that digital health payment is largely service-based. Telehealth and RPM are reimbursed through specific billing codes, while AI tools are mostly paid for indirectly, right? And that creates growth, but also fragmentation and misaligned services, right? That's the downside. Outcomes still aren't what the system consistently pays for, unfortunately. But it feels like, to me anyway, that we're at this inflection point where reimbursement is shifting from what we do to what works, right? And so the question right now for us, I think, is whether we build that transition around these fragmented solutions that we have, or around shared infrastructure and best practices. So, and if there's anything you want to add to that, feel free. But I guess I would go to Ryan first and just say, do you think we're moving toward service-based reimbursement like RPM, CCM, or outcomes that are outcome-based payments like the access CMMI models as dominant pathways? Where do you see us headed?
I hope, I think the answer is probably both, but I hope more of the latter. I think access is really exciting to start paying for outcomes that largely most people correlate effectively with cost savings, but can be more clearly demonstrated and more quickly demonstrated is probably the most important part. So I think the answer is both, but I hope we start to see more of the access type models. Access, I think, was before access, there was some outcome aligned payments in the Medicare Diabetes Prevention Program. I had to look pretty hard to find those, but hope it's more of the latter.
Thank you. That's helpful. Sharif, you have thoughts on that?
Yeah, I agree. I think paying for outcomes is a very important North Star, and access is taking a nice step in that direction. The only thing to keep in mind, though, is the U.S. healthcare system is still built on a fee-for-service chassis. So even if you have, an access outcome payment or some Medicare shared savings payment or an ACO, unless you're in a truly capitated environment, which only 1 in 10 physicians are, working at a VA or a Kaiser,
right?
For clinical AI systems that take away the appointment, right? So it's one of the main objectives of the potential of clinical AI, if doing something that historically would require a licensed provider, and the US healthcare system's economic incentives are to make money off of the labor of licensed providers. So even if you have some outcomes payment, if you're giving up that revenue stream, you will not adopt in a fee for service world some solutions that directly threaten that revenue stream, no matter how perfect it is, unless you're in a fully capitated environment. And so one thing I'd add to that is that we actually published a little piece on this in the New England Journal Catalyst magazine about a month ago, is that in addition to that, we need to add a framework like output-based for medical decision-making, MDM billing, to some of the asynchronous care services that don't exist right now. I'm happy to talk about that more, but otherwise, even if you are incentivized with outcomes payments, some tools will be too punitive to use that are important for increasing productivity.
Right, makes sense. So, and I know we have access to that, or at least a link to that. Maybe we can put in the chat so people can read that. I think we've all read that on the panel here, and it's extremely thought-provoking. It's really good. So I would encourage our listeners to read. Jeff, what are your thoughts around this? How do you see
I'm
it
probably
going?
going to land somewhere closer to Sharif. I agree with Ryan that like it's great that we're and I think we will end up with both fee for service and outcomes based. I think it's great that we're moving towards outcome based. I think it's a little bit of a double standard though, in that we've allowed, to Sharif's point, we've allowed the rest of healthcare to operate on a fee for service basis for so many years, and they fought like really almost tooth and nail against going towards outcomes based from multiple perspectives. And I think that my concern is, I see companies from, Series A to, public. And I think that we're also losing the fact that we can't actually, to Sharif's phrase of sit on the chassis of fee for service, we're losing a lot of innovation that could be used relatively quickly. And we've already lost companies that have had great products over the last decade because essentially the fee for service system is not set up for this. There are some temporary codes that exist today, not really getting reimbursed well, maybe a few different health systems. But for the most part, the outcomes-based programs have become kind of like, I think, the hope or the North Star to work towards. I'll be honest, I love the concept. I think a 10-year program, though, that's a lot.
A long runway, right?
To your point, like Ryan, we can get these outcomes so quickly and we can figure out what's going on so fast. We don't need to wait 10 years. We can make decisions. And I know there'll be interim steps in between that, but I would love to see something like the Health Tech Investment Act come to fruition more quickly.
Right.
Would kind of be where my head's at.
Okay. Do you want to talk about the Health Tech Investment Act real quick? Do you just want to for our
Yeah,
listeners, just throw
from
that? Yeah.
from a high level, for me, is that I went to Medicare with groups like AdvaMed, DTA years ago, and when we had software based products or software only products, regardless of what they were for, and essentially there's no benefit category. Medicare, if you go to Medicare, they're like, we don't create benefit categories. That's a congressional issue. And so until one's created, we're just going to kind of sit here. We can't do much. And to their credit, they've become much more innovative recently, and they're pushing different programs to, I think, make up for the gap and to try to get innovation out to the people and to medicine. But I think until that reimbursement category is created for AI enabled services, and hopefully more broad than that, the only thing they've really done to date are the T codes and the G codes for software only products.
Right. Software is a medical device. So it's a pretty limited, lane that we have there. So switching really quickly then to, or sort of riffing off of that, I guess, regarding pilots and models, what do you think are the most common reasons that those fail or succeed right now? If folks are wanting to apply for these things as we move into this, I guess that is what's top of my mind as you're all talking. You guys have all had lots of experience here. So I'm going to move to Ryan real quick, and let's get your thoughts on that, Ryan.
My thoughts on the pilot I think you have to have clear evaluation criteria. I think where a lot of pilots struggle is, let's just say it's a total cost of care pilot. It takes time to establish a control group, to do a difference analysis, for claims to land, and you're 18 months out with not a lot of volume to determine was it effective or not. So I think key to any pilot is understanding, what good looks like, executing against the good, moving quickly, and adjusting quickly based on once you get it out the door. Loaded question, but I think that's where I'd probably start is the evaluation criteria being clear.
Yeah. And so within that to your point about, that's really, it's a tough amount of time, that 18 months and getting enough, of a control group and everything ramped up versus this 10-year period that we're looking at, which is super long. Where do you think the sweet spot is?
Well, I think the 10-year access model is it doesn't it will not results will not only be shown after 10 years. So there's a huge component of access where participants must share outcomes data in year one. And so I don't think it will take 10 years to land. I think we'll have a pretty good idea well before that if this is an effective model and a deflationary model.
Ryan, I have a question for you, dude. How do you think about the fact that, sorry, I don't know the moderator here, but it's just
No,
curious
no,
because
it's a discussion. Bring it on.
yeah, yeah. How do we think about the fact that Access pays less than um, traditional alternative codes like RPM, RTM, CCM, PCM, and they can't be billed at the same time, and they can't be billed by the health system?
How do I think about that?
Yeah, well, yeah, I would imagine that, you know, Cadence probably uses CCM, PCM codes, and the economics, if I were in your shoes, would say like, why would I use this program when there's this other program that doesn't have a contingency and pays more? Access pays less, and you may not even get all the payment.
Yeah, I think they're different programs. So I think
Mm-hmm.
a significant RPM program for a congestive heart failure patient is a very different program than an access model patient. I think it's for patients to choose which one's right for them, for providers to choose which one is best for the patient. I think if access is successful, and there will be winners in that space. It'll be those that can effectively move the needle on the outcome aligned payments, the weight reductions, the lab improvements, the blood pressure reductions at scale very efficiently. And I think the only way to do that efficiently is by incorporating AI into almost everything you're doing. So I think they will ultimately be different programs for different patients. And I think it's up to the patient and provider to decide. I think it's a great question, but it's going to be very different than a model we have stood up today.
Yeah.
Yeah, that makes sense.
Let me, this is a question and a statement maybe, is that one of the challenges I would say, Brooke, that, and Ryan, I'd be interested to get, actually, Sharif, your perspectives too, is I feel like now beyond access, right, there's pilots with health systems, there's pilots with commercial insurers, government insurers, like there's all sorts of different programs. I oftentimes don't see a real carrot at the end of it. There may be discussion of it, but I don't see a carrot in writing very often. It is do this. Sometimes you may get paid during the pilot, sometimes it may be unpaid. But then what do you get at the end if you're successful and you meet those metrics? Like not just payment, but what does that mean for the long term? Like what does that mean for your relationship with those entities? I know it's there sometimes, but do you think that we're headed towards a situation where health systems and insurers will be willing to commit that if we hit those value metrics that you kind of mentioned, Ryan, and we hit those endpoints, that we can rely on the fact that we'll be then getting revenue in not like perpetuity, but for at least the time being?
Sharif, I'll let you take
I
a
was going
stab
to
at that
say,
one
who is
first.
Well, I
answering?
mean, I guess I think from the access model, I think the intention is that would be the case. There'll be some shifts and changes and some decreases in payment because they're looking at have this be deflationary. But access, at least as a metric, I don't think it's designed for health systems. I think it's designed to be something separate from health systems, right? Like this is something that the health system cannot bill. The access work can bill. This is something
No.
that, yeah, I don't know if that's your question,
No,
Jeffrey,
but
but
I think what I'm saying is if you're going to put all this effort in to do a pilot, what do you get after it if you're successful? Because right now, in most of these pilots, it's not guaranteed. So no matter who you're
oh,
doing it with, I think that's where I'm headed is that these are companies with sometimes limited resources, and even participating in a pilot can strain an organization's infrastructure. What do
oh,
you get at the end
okay.
of it?
Yeah,
And
this I could share my 2 cents on. So usually it's not always the case. Depends on where at which level of the organization the pilot's taking place. If the health system is going through the rigmarole of doing a pilot, usually if you're at the right level of the health system, they don't want to put all that energy and time and infrastructure if it's just going to be something that lives in pilot land. One of the health systems we work with, for example, say never use the word pilot with us. It's phased implementation because our CIO does not want any pilots. Right? It's just like projects as a distraction. So, to Ryan's point, as long as you're aligned on metrics and success metrics from the get go, and you have an understanding of where the world will go, so long as things are um, as advertised ultimately post that first set of the phase implementation. I have seen health systems doing the right set of the organization unless things change in the macro environment. Commit to that, or at least have a good faith intention to commit to that.
Interesting. So that is a big challenge in the current environment, right? For um, changes typically follow at least like that moderate adoption and demonstrated value of tools. So health systems, as you just said, are facing this like overwhelming variety of tools to choose from, right? And you guys are in this business, and so with these margins, right, that they're and very little room for error that they're operating on, how are your companies how do you go about incentivizing adoption of your tools by health systems when payment remains in question? I mean, I feel like that's a for folks who are working in these startups areas, this is a big, and for health system folks, how do we decide where to land? Can y'all maybe give some insight into that?
I'm happy to share
Yeah.
just because something came to mind. So adoption, once you're in a deployment, there's a top-down and bottoms-up approach or dimension to it. Um, the bottoms-up is the most important. Who's the utilizer of the tool?
Mm-hmm.
And how do you make it so that it's integrated into workflow as much as possible? So sometimes that means your system's integrated into EHR, which also, Jeffrey, is another kind of like some cost the health system goes through. If you're integrating into the EHR, there's a lot of resources that go into that, and so that creates some stickiness.
yeah.
And I think that's one of the most important things to make sure that is engaged. And we've looked at many dimensions on how to make sure that uptick happens. And the most important we've always come back to is that this is hitting them right in their workflow without extra work, not
Yep.
requiring them to change workflow. And then there's the top-down piece, which is the billing component. So that the CFO is not looking at this line item, the spreadsheet, and be like, why are we paying for this, or how is this affecting economics? And I think of that as gas on the fire, and how to get institutional buy-in and how this fits in. Because health systems, if you're selling to health systems, they have complex economics and budgetary gerrymandering, how they think about the investment in any kind of technology solution.
Yeah, makes sense to me. Jeff and Ryan, do you have thoughts on that? Ryan looks like he
Yeah, I
definitely
mean, oh, go ahead, Ryan.
Well, so we launched in 2021. I would say like the world is changing. So I would say if I met with 10 physicians and introduced Cadence to 10 physicians in 2021, there would be two that would say, "Where have you been? This is a great idea." And there would be a majority that are saying that would have told me no. I think if I had that exact same conversation today, which I am having that exact same conversation today, those numbers have shifted to 5 being all in and maybe 2 being on the fence. And that's just in 5 short years.
Mm-hmm.
So I think these tools, like ultimately, I would say a lot of our clients think good medicine is good business. And if you're doing right by their patients and you're making their life more efficient, you're going to be in a good spot. So there was a fear when we were getting going that physicians and we deploy. I'll talk about a remote patient monitoring product for this example. Is a cardiologist would say, well, if I put a patient on this tool, I'm going to see them less. And to Sharif's point, like maybe they're on an RVU model, I'm going to see this patient less. That's a concern for me. What we saw is that patients really like the tool, and maybe this cardiologist had a 3-month wait list. So what they could potentially do is shift that patient from a once every, this is a chronic patient, shipping that patient once every 3 months to a once every 4-month visit, get some people off the wait list, And when we looked at this cardiologist panel a couple years later, we saw that they actually saw that patient more, albeit less frequently, but over the long haul, they saw them more. That patient no showed less. They were able to get patients off their wait list. Their panel grew. So it's kind of one of those win-win solutions where initially it was met with hesitation of this is another hand in between me and my patient. I'm worried about the relationship being broken. But at the end of the day, the patient loved the service. They were more engaged. We were arming the physician with tools that made better use of their time together. So their visits were more impactful. And it was a win-win-win solution. So I just think at the end of the day, if you're doing right by patients, if patients are often lost in this conversation, if they enjoy the service and you're arming the physician with insights, not data, that's just, there's a big difference in data and insights, but if you're arming them with insights to do their job more effectively and better and take better care of their patients, you're going to be in a very good spot at the end of pilot phased implementation, whatever you want to call it. But that's the place you want to be at the very end.
Excellent.
I
Jeff?
completely agree with that.
Yeah, so I couldn't agree with Ryan more. I would say that we end up actually, we've done this several times. So first of all, we take a multi-stakeholder perspective, which has come through from Ryan and Sharif. Like we don't just we look at the health insurer, we look at the physician and the health system, we look at the patient, and then we also look at the company that's sponsoring us, basically it's having us do the work. And we've actually built economic models to Ryan to kind of look at your point, where we've actually modeled out everything from marketing, like everything that goes into it, literally that goes into you supporting that program, including EMR integration, Sharif, if it's necessary. And we actually will build it out to prove to a health system or a physician practice, like good medicine is good business. That doesn't mean that everybody in the system agrees with that, though. And that doesn't mean that they won't fight it necessarily. Again, less on the clinician side, but there are actors that will sometimes put up roadblocks against that. And so what you have to do is prove that that is true. And I think that the proof is in the pudding, not to use an old saying. It's like I said, we built models to look that out, and we'll build them out over 1 to 5 years just to kind of demonstrate that. I also think that I think that RPM is a great example. Cardiologists, what are over 50% of the specialty users? We pull the claims every quarter. And we see what the utilization is. And I think they figured it out relatively quickly, though Ryan, probably better. But like they figured that really quickly how to use tech as a way to improve care because there's so many conditions that can benefit from it. So yeah, I think a matter of is just like really instead of being like you have to believe, you need a reason to believe. Well, here's the proof, which I think we can figure out at this point because we have enough data and we've had enough time to show that.
Yeah, actually, I want to double click on something that both Ryan and Jeffrey were saying, but it really struck me with some of our customers. What Jeffrey just said, good medicine is good business. I've been surprised by how much for certain customers, especially academic medical centers, where key decision makers weirdly don't think first in terms of economics. They think first in terms of how do they solve their problem delivering better care for their patients. Like actually think in those terms. And then they're like, we'll figure out the economics afterwards. And I don't know if this might be partially because we operate in a primary care setting where primary care is already regarded in many tertiary care centers as like a loss leader. And so they don't really pay as much attention to the economics and more as like a Faustian bargain that's necessary to be able to get all your electives and imaging and procedures and everything else, which happens in some environments. But I do think for entrepreneurs or people out there, sometimes you make the sale not talking secondarily, which is weird to say, not always, but sometimes it is really the case. Like just solve really good quality care and then back into the economic model from there.
Sharif, if I could just a little story about that from academic is there was an academic medical center, and there's 70 some people on this call, so don't all go bum rush them, even though you might. But we were working. I was working with a client, and there was a T code that applied to their technology. It was basically AI sitting on top of something else, and almost nobody in the U.S. was getting reimbursed for it, except for academic medical centers and a couple in particular. Because some of it was they had the reputation and the relationship with the health insurers to be like, you're going to pay this and you're going to pay it at this rate. And it was interesting to watch them push some of that through. I'm not saying it'll happen with everything, but it was actually quite interesting to pull the claims and get the proof and be like, oh, you are actually. And so they were. And so it was interesting to your point. It was the clinicians driving it, and the admin were like, we'll get paid for it. And they did. And it was interesting to see that technology flourish in that setting.
Unfortunately, we don't all have that power, right? Not all of
Correct.
us.
And it wasn't scalable. So
That's not scalable,
as a strategy, it's not necessarily scalable, but as a way to try to prove use and utilization of the temporary codes, because you want to do that for your category one, it wasn't a bad strategy.
Yeah. Well, let me shift really quickly since we're kind of at a halfway point here. I want to talk about evidence. This is really important, right? Because we all said here best practice is a big deal for folks. We want to, good medicine is good business. That's based on best practice based on evidence. And sometimes that gets lost in these conversations as we move really quickly through trying to figure out what the guardrails should be, around reimbursement and regulatory actions. So I guess I want to ask you guys to give me your general sense of what evidence will really move payers from pilots to contracts, right? And you've sort of answered that question for practitioners, but if we're looking at metrics and evidence for payers, do you have thoughts on that? How does that differ too? Like, where's the misalignment with the academic or the uptake from the patient and the provider side? That's a tough question, but I think it's important, particularly from the American Heart Association's perspective of facing everything on evidence. So it's a quick question. I'll punt to Sharif. You have a thought on that?
Sure. For us specifically, and it'll be unique to each person's, the change that is being asked or the thing that you need to believe for a payer, we compare legacy with novel payment and show how the new payment approach is both lower costs and improves outcomes. And so to be more concrete, we talked about this a little bit in a New England Journal paper, is the big asset we're trying to have for payers is to, the best way to describe it is that most of the US healthcare in the fee-for-service world is paid for by paying for the Uber driver's time behind the wheel of the taxi, right? And we're saying, can you please pay for the Uber ride instead so we can have a Waymo, right? You're driving, and we're going to compare. We're going to look at how much it costs when you're paying for the driver's time, and look how much it would cost if you paid for the ride, and you can give you a discount in paying for the ride, and look at the differences in outcomes and access when you have that. So that's the approach that we're taking. And very concretely, the way we give it, we try to use the tools and language that payers already understand to make this leap. So for certain, very narrow set of things, payers already pay for what's called medical decision making. That's sort of like the Uber ride, that output of what takes place in the clinical context. That's famously an option in normal evaluation management billing. So if a doctor sees you in a doctor's office, or whether in person or telemedicine, that doctor will bill either based on the time they spend with you or medical decision making, MDM, the output of care they delivered. So if that doctor uses an AI tool, like let's say a scribe, to become more productive, and their visit no longer is a level 4 30-minute visit, it would otherwise be like a level 2 15-minute visit, they can still bill level 4 because they can bill based on the output to MDM. And so we use that same language. We say, well, right now, make that visit asynchronous, take place over text. The doctor bills digital EM, and they can only bill based on time. So if they use any AI tool in the asynchronous world to make themselves more productive, they're penalizing themselves. So we're trying to show the payers, look, if you pay for the output and we let these physicians be more productive, and by the way, digital EM pays 1/3 of the amount of normal EM too. So it's a lower cost care, only makes up 0.1% of all claims because it barely pays anything. It's also why if you do text your doctor, they always say, please make an appointment, right? Because they don't get paid as much. So as long as we show that apples to apples, this can significantly reduce costs and be a better way to align incentives, payers are aligned with thinking about that and showing the proof, how the proof's in proof. I don't know if that helps answer that question, but that's at least how we approach the question.
Okay, no, that's helpful. Jeff, do you have thoughts on that? I'm going to ask you
Yeah,
both. Yeah. Okay.
for days.
Yeah, that's
I think I think it depends on who you're talking to as a health insurer when you say payer. So,
yeah.
if you look at it, right, what's the average life expectancy in the US now? 78, 79, right? Medicare looks out 10 plus years, 10 years, right? But what we're seeing now is that the commercial insurers are really looking out like a year, some of them, two, if you're lucky, three. But it's gotten quite tight. And so, Sharif, I think when you talk about like I think the immediate impact of like upcoding, downcoding, and things like that is much more important to me or to them. I think, I think there's still because it happens immediately, right? That's an immediate impact versus I think the old way we think about is, oh, well, kind of more of a cost effectiveness or cost utility approach was somehow we look at things that were more expensive or new. And, that takes an amount of time. And not to say that that's still not used ever, because I think there are certain things where if it impacts a disease and it's such good clinical practice for like CHF, yes, they're going to adopt it anyway. But we have clients that have showed 50% cost savings that have not moved forward, partially because of the clinical area that they were in, and partially because of the amount of time that it would take for those benefits to be realized. So I love what Sharif said about like I said, I think economics is really the name of the game, especially when you look at the ups and downs that payers have had. We know so many payers that are like, we're just not doing new things this year. And that's literally the statement that they say to us. Now, that's not true. They're not going to do something new that's going to take 5 years to realize the value because right now they're worried about cutting staff or hitting their numbers because they're corporations. So again, I'd emphasize what Sharif said about really dive into the depth of the coding. And then there's some things that are just, they also know they're just going to be forced. They kind of have to pay for, right? Because there's a new code out. And yes, they can make a choice of going against it or not, but they're not going to. I think what's actually also going to be really interesting, and we don't have to get to this now, is what's the patient portion of this? Because that's the other thing that I think really gets ignored is it's not traditional reimbursement, but in a way, like when you do RPM or certain codes, right? Like what's getting sent home to the patient that they're not expecting? Because this is very new for them too, because they're used to being like, I have to go to the office, I have to do this like physical thing in order to receive my health care. And they associate that with also, I think, copays and coinsurance.
That is an excellent point. Brian, do you have thoughts on?
I just to build, I agree. Like, MLR is important to payers. I think clinical outcomes are important to payers. STARS measures, rate them on their ability to achieve certain thresholds, and I think those are important. I'd add, maybe is just engagement. So, driving engagement in their membership is often difficult. So what tools are driving engagement? Are they utilizing certain things 20 times a month? That seems to be pretty interesting. If I can engage somebody 20 times a month, perhaps I can, encourage them to develop other good habits, to get some labs done, to do a wellness visit, other things that they're incentivized to do. So I think at the core, it's really difficult to move outcomes without engagement. I think that's lost in a lot of places. And I think what payers are looking for that providers can stimulate more effectively is patient engagement, meaning doing something often, following a pathway, staying on a pathway for an extended period of time. I think that's super valuable to payers.
That's excellent. Okay, so I cannot see, Rachel, our folks behind the screen, I cannot see any questions. I can't see the chat at all. Are there questions in the chat? I don't want to ignore any of that. Can somebody?
There are two.
Okay.
There was one earlier that is, what is your view on the use of in silico testing and alternative designs for SAMD to evaluate cost and outcomes?
All right, who wants to tackle that one?
I'll happily try. I'm not sure. I can imagine that's useful for demonstrating concepts and priming a payer with ideas and kind of like revving the engine and warming up the engine. But I suspect payers are very much traditionalists and creatures of habit and risk averse and will want to see real world data as well. I mean, they're skeptical enough with real world data as it is. So I imagine in silico would
Yeah.
probably be useful for just, framing the conversation. Just
Yeah.
one take.
Any other thoughts on that, or it's pretty, yeah. Okay. What was the other question, Jeff? Can you?
There's now 3 total.
Oh, good.
Hi, this one's for Sharif. Hi, Sharif at UpDoc. Are you creating AI RPI for persons living with dementia and their in-person remote family members? What % of your patients are 65 plus?
This is a great question. Hopefully one day, we right now are not for patients who have cognitive impairment, to start just for safety reasons. But that is actually very much on our roadmap, and it's come up many times, because of the importance of having continuous care uh, for patients where you have an activated family member and there's a lot of follow-up that's necessary, to make sure they're handling all the psychosocial needs. So not right now, but hopefully soon. And what % of our patients are 65 plus? The majority.
Excellent. All right. I see Kay has a question. I know Kay well. How do you recommend that small technology companies partner with medical institutions and/or payers to conduct phased-in implementation pilots?
I somewhat hit on this before, but I would be very clear about your value proposition. I would hit it repeatedly and be very convincing. Take good care of patients, have good results from both patients and providers, and do not generate more work for your end user. And I'm not saying anything that's earth shattering here, but I think these are table stakes if you're going to be a small technology company partnering with some of these institutions.
I think in addition to what Ryan said, be very clear what you're getting out of it and be very clear what you're putting into it. Again, not rocket science, but and what I mean by that is if you're doing things to generate evidence, or if you're doing things and you want to make sure there's going to be, like I said, a resource allocation, and output that you have to do as a company, be very clear what those are and understand that how long they're going to last and again what you're going to get for it, because that's really critical, because we've seen companies, smaller ones, that they don't survive a pilot because they weren't really prepared for it, and it's not because the tech's bad, it's because of other reasons. So yeah, I think be very aware of what you're putting out and who you're working with. There are some organizations that we send our clients to that they're kind of like professional pilot organizations or phased implementation organizations. Like that's what they do. They love to do them. That doesn't mean it's going to be great for your organization.
Makes sense. I really like this next question. In your opinions, is this space of AI optimized solutions to manage chronic conditions remotely saturated? Do you think there are any existing or emerging gaps? Or have we just covered it all by now?
I think there are gaps. I don't think we're doing a very good job as a healthcare system nationwide tackling these issues. So I think I can read that a bunch of ways. I mean, it's saturated. There are a lot of competitors in our space. Yes. Is there improvements to be made? Absolutely. So I think different vendors or different solutions are tackling different issues. This is a vast canvas.
Mm-hmm.
So I think there are a lot of players in the space. Some are very good at certain things, but we're ultimately not doing a great job moving the needle here. So there's more work to be done.
Yeah, I completely agree.
Okay.
Yeah, just primary care in particular and in chronic disease management, we have so much work. We spend about 2 to 4% of our healthcare dollars in primary care. Most other developed nations, it's like 2 to 3 times that. And if you look at our NHANES outcomes, It's just one of the things that back when I was an investor, was always made me a little sad is despite all the innovation and companies that the ecosystem would generate, the final needle, there's so many components to it that the final scorecard continues to be stagnant in many dimensions. We do make slow progress, but there's a lot of work to be done.
Maybe I'll just, the question 3 down is asking a similar question, is how difficult or easy it's been to achieve EHR integration, knowing these platforms claim to also have remote monitoring solutions. At the end of the day, it's very focused. Focus is a key element. So is an EMR system going to be delivering the best, like let's say an EMR is trying to do remote patient monitoring. Are they putting all of their resources into it? Is that where all of their enhancements are going? Are they able to offer an end-to-end solution? Is it a piece of the puzzle? Again, a piece of the puzzle might be perfectly fine for a buyer. But I tend to think that people that are very focused on certain things deliver the best product, and an EMR company is probably devoting their best people, their top dollars to their non-RPM offering. So focus at the end of the day is very important. I don't think you want it to be a side of the desk exercise.
Okay. Okay, so I think we've got 2 more. We've got time. I think we could take these 2 because this next one is pretty interesting. She's observed several technology-only companies transitioning into, they keep moving on me, into providers in order to bill through CPT codes, effectively embedding the cost of their technology within the already low margins of these codes. What are your thoughts on this approach, and what alternative strategies, importantly, do you think we could consider? Jeff, I see you nodding.
Yeah, I'm thinking, this is a tough one. I'd love to hear the rest of the panel too, but I look at what iRhythm did originally, which becoming an IDTF, an independent diagnostic testing facility. I think they're one of the early, they have hardware, but one of the early, quasi-digital health companies that went this route. It worked out quite well for them. Obviously, we can follow their stock price and see how well they've done. It was a good move. In my opinion, we look at this option for a lot of our clients. For most, it doesn't fit for them to transition into a provider for most. But that's more because of the infrastructure they have set up, the amount of time it would take, what it takes to get an MPI, all that fun. Like, it's just not there. I actually think this is a good option, though, to keep on the table and look at. I really do. I think especially today, again, with no benefit categories, depending what your product is, and I think Ryan just said this, right? If it's a piece of the puzzle, you're actually probably better off working with a larger company instead of trying to work directly with the customer. Because if you're a piece of the puzzle, that might not be enough to get your foot in the door, and you might not have a way to get paid for it. Versus if you're the provider, it is a viable path. It's that chassis thing again, Sharif, right? Like, we're on the fee-for-service chassis.
Right.
100%. Maybe I'll just add here too. I've thought about this so much, like frameworks and what makes a tech company versus a tech-enabled services company, and I think every business is different. One thing to just keep in mind is if, depending on what your company is and what you need to do, how much you need to interact with and engage with the healthcare system and the primary care doc, having a separate fragmented system can sometimes be very challenging. And just be thoughtful about if that tech-enabled service is duplicating care or feels like the iRhythm example doesn't feel like a tech-enabled service to the overall healthcare system. In order to make sure that it's adopted and as seamlessly integrated into the patient's journey as possible.
Okay. Well, I can see that, or I thought I could see that Jeff was answering directly a question, but it's an important question because it focuses on behavioral health. So, Jeff, do you want to tackle that one real quick, and then we can move down? I think we have some time.
Yeah, I'm glad everyone can see how slow I type. So right now the use of RTM codes in mental health is very, very low, like negligible. The bulk of those codes are actually being used in orthopedics, and the bulk of that is actually by physical therapists. Um, that there's some use in pulmonary, though that is low, but potentially growing. I think that part of the challenge is, and so I'm a PT by training as well. Actually, I didn't say that in the beginning, but that was my background. Very busy. All providers are busy. They're very busy. They might be seeing 3 patients, 4 patients at a time. A lot of this had to do with the way that they integrated those services into their version of an EMR, right? There are PT specific EMRs. So I think operations is actually probably the biggest hurdle. And I think also educating the provider versus like in a PT clinic, those are like, I'm just going to name a large one. It's nothing. I'm not endorsing the brand, but like ATI, they have like 900 clinics or something crazy. If ATI says from corporate, you have to start doing this, it's going to get done. I think it's a little bit more difficult and there's a little bit more infrastructure that's required in mental health because they don't have the same corporate infrastructure that you might see in some of these other types of practices. So again, I'd focus on operations and infrastructure and then also the benefits of it.
Awesome. Thank you. All right. There are two here I think are important. They're sort of on different ends here. Do you have any insights into reimbursement and billing with using AI in acute care situations? So, ICU, ED, places we're going to see some real shifting loads. Do you have any thoughts on that? That's a tricky one.
I was typing just in the inpatient setting, not the ED setting, usually, unless the patient's admitted. Payments are paid based on DRG. And then there's also professional fee on top of the physician services and other, PT service, et cetera, other professional services. The DRG is very nice because if you're selling to the hospital, they get a bundled payment. So if you're truly improving something around costs or length of stay, there'll be some economic incentive to pay for what your product is.
And Sharif, how do you think that this also changes now with the 5-year expansion of the acute hospital care at home waiver?
Yeah.
That's a really interesting question. I haven't given too much thought because I think the DRG system still applies to there where you just get to have a home care.
It's just
I have to think more about that. Yeah, I don't know.
Yeah, I think right now it's like it's a margin issue, right? Like I think that like you get better margins potentially with that type of care using tech, obviously. I mean, there are still some models that we see that are very human based, even though it's acute hospital care at home, and there are some that are more tech enabled. But yeah, I think it's going to be more of a margin issue because you're right, it's still a DRG, but it is going to be interesting to see how that may change care over the next few years. Now that there's actually a longitudinal timeline and an off ramp for that program, which there wasn't, 6 months ago.
Mm-hmm. Yeah. Actually, for those who may not know, because Jeff and I have been using this target, DRG is diagnosis related group. It's a bundled payment that the patient or the payer pays for that care that is related to the diagnosis and the complexity and complications. And generally speaking, the inpatient setting margins are less than the outpatient setting, just on the health system as a whole. Anyway, it's interesting. It's also the history of how healthcare was and the DRG was set up, like why that's been the case.
Yeah. Thank you. Brian, did you have a thought?
Well, there's one other question that's I'm going to go a little off script here, but it's talking about the challenges in the realm of digital health reimbursement. So one thing, I'm going to go like a layer deep into the physician fee schedule, but one thing that often gets overlooked is something called a GPCI. It's called the Geographic Practice Cost Index. So what that means, they use Medicare will adjust reimbursement based on where the service is being performed. So, for example, a level 2 office visit in Alabama is probably $50. That same office visit in Los Angeles is probably $60, $65, something around there. Now, totally logical and in-person brick and mortar care delivery for there to be a difference, right? They account for it's rent's more expensive in Los Angeles than it is in Alabama, so on and so forth. However, when you move over to digital health solutions, that makes a lot less sense. So what if the cost to deliver the service is exactly the same? So I'll use our business, for example, is if I'm treating congestive heart failure patients with RPM in Alabama versus Los Angeles, the reimbursement in Alabama is significantly less. My cost to deliver it is the same. However, the prevalence of that condition in Alabama is significantly higher than it is in Los Angeles. So what kind of incentives does that create? It doesn't, it makes, it's one of those, makes perfect sense 25 years ago, brick and mortar only delivery. But when you move to a virtual delivery system, it doesn't make a lot of sense. You're almost disincentivizing digital health companies from pursuing working with folks in Alabama, Mississippi, Tennessee, even though that's where a huge amount of patients are struggling with these illnesses. So one challenge in the digital health space that I think is often overlooked, starting to get some attention now, but it doesn't translate well from the old brick and mortar system.
Great. That is something we wrestle with on the daily. So appreciate that comment. Real quick, let's talk about the pediatric question. Does that are they better situated than adults? Not as well situated? How do you feel like they're situated to develop or adopt tech for cost savings? That is an interesting question. It's
Yeah,
I do not know.
Yeah, I don't
So
see
I
a
will
lot.
defer to my panelists.
Yeah, I don't see a lot of pediatrics coming through. I mean, if you think about it, like most of the pediatrics that I end up seeing if I'm doing work is going to be in diabetes.
mm-hmm.
That's where most of it I see it, but that, I don't think that's what they're getting at. It's just, but yeah, I don't see as much of it. Um, it's an interesting dynamic though when you're working with minors and you have to deal with parents and
Yes.
the communication and the data transfer and then things like that. And I mean, there's a lot to consider.
It's a very complicated, yeah, lots of complicating factors there. Okay, so we have 9 minutes left. I want to give each of you an opportunity to wrap up your thoughts on where you think we're heading. We've been sort of all over the map, although this has been a really good conversation. If you had to give advice to those of us in policy land who are trying to help figure out where these guidelines should land and how we should incentivize, the work that you guys are doing and still make it workable for the broad categories of providers that are out there, what would it be? One piece of advice for us. I know that's a lot to ask, but leave us on something high note.
I'm
We'll
happy
go
to
with Sharif.
start.
Yeah.
Yeah. Yeah, I probably would go to the title of our New England Journal paper, which is AI in the clinic, don't pay for the tool, pay for the care. So, as we think about clinical AI emerging, and we define clinical, like true clinical AI, as when an AI does something that historically a licensed, billing provider would do. As clinical AI moves in that direction, we have to ask ourselves, do we want a world where we're paying for the tool the way the system's already paid for a software medical device that results in a situation where, these clinical AI solutions take away easy visits from primary care docs, maybe creates more work for primary care docs in the back end, and the PCP who's already overworked, overburdened, going into concierge practice while the silver tsunamis, been hitting us, have more just the incentive structure creating more fragmented care with them? Or do we want a world where we're paying for the care and the purchaser is not the payer, but the physician? And the physician is also a better market force. And you have a world where the primary care doc can earn some margin while the AI tools are utilized. And you have a situation where maybe primary care becomes more viable. Maybe a primary care doc makes more than a specialist because they're the orchestration specialty and can utilize these clinical AI tools. And we have more focus in primary care while still having it deflationary because, this is something that, it would, while it's creating margin for them while happening in the background, they get paid less than if they were to do this themselves at the visit. So that would be my big ask in order to align incentives, make sure the patient gets the right experience that's integrated with the rest of their care system, and make sure tools like ours don't fragment care.
Yeah, love that. That's a lesson we're learning with telehealth, have been learning, still trying to align that integrated care. We know that's something we're still dealing with. And I see Ryan shaking his head. Ryan, do you want to?
Yeah,
Go ahead.
I have no disagreement there. I would just say, if based on how the question was asked, I would say focus on the appropriate guardrails to reward the good actors and penalize the bad actors. In any of this, um, there will be bad actors that, for the wrong reasons, are like, I'll use the example from a couple of years ago. There was like rampant catheter DME fraud. Like, that does not mean that every DME provider of catheters is a bad actor, but that whole space has been tarnished because of the bad actors. So I think the government's doing a pretty good job here stepping this up, is like combating fraud, eliminating bad actors, rewarding those that are driving performance through appropriate guardrails is obviously very important.
Great. Thank you. Jeff?
Yeah, I think as a market access person by training, I can come off as a pessimist, but really, hopefully, it's a pragmatist. I would say follow the money, and that doesn't mean follow the money in what you do. Your product working and having clinical benefit. To Ryan's point, there are bad actors. I assume that that's the bare minimum for entering the market, is that you have a good product that works. I think figuring out how it fits within the system and how you can generate revenue is a legitimate concern, and how you're really going to impact the healthcare system. Because if you can't figure that out, you're not going to get to patients or clinicians or to payers, and you're not going to be able to have the impact that you know that you can have. We've had more change in the last 2 years than we probably have the 10 before, to a certain extent. So I would have hope. EMR's meaningful use was in 2011. It wasn't that long ago. And 2014 was the deadline. So it's not you. It's not that everything's against digital. Digital is very broad. The healthcare system moves very slow. It is like turning a very, very large boat. But we are actually turning now, and we are starting to see things move, whether it be access or product reimbursement. It's starting to happen, and it's going to take more time, but we're getting there. But make sure you keep that in mind of not just following clinically what's happening, follow economically.
Excellent. That's excellent. All right. For those of you who have questions we didn't get to, we are all happy we can answer these questions after the session ends, and we look forward to doing so. I want to thank all of you for your time today. This was a really insightful discussion. I really appreciate it. I enjoyed it. I hope everyone listening in did as well. And I think we will turn that over, unless back to Rachel and Pat.
On our end.
All right. All right. Well, thank you all. Have a wonderful day. We appreciate your time.
Thanks so much, all.